introduction. I really appreciate it. I think I'll just kill this one and use this microphone here, if that's okay by you guys. It's really good to be here again and see so many friendly faces. I believe this is my second event with you. I chose this topic because a lot of the times people think that once you have an aortic dissection, you do surgery, you are cured. You actually are not. I want you, hopefully, by the time I'm done, and especially now that we're all relaxed with Dr. Gossel's lectures, when we're all done, I hope you will know or get to understand that having an aortic dissection, once you have it, it's the same thing as having high blood pressure, having diabetes, having high cholesterol. We give you medications, and you have to check in with your doctors every single year. And we don't quite cure it, per se, although there are different things that can cure high blood pressure medication now for obese patients, so on and so forth, and diabetes. But I don't want you to think of a dissection as something that you cure, but something that you monitor over time, even after surgery. That's the biggest message. These are my disclosures. And the first one is very relevant because I'll be talking about some investigational device that I use to treat patients with aortic dissection. So the classification of aortic dissection really centered, the old one, around the question of whether are we going to treat the patient with surgery for Stanford type A aortic dissection, or are we going to offer the patient medication, so treat them with blood pressure medication. That's how we used to classify them. There's another classification that's also old, which is called the DeBakey classification. This classification has a few more nuances. It gives the surgeon a better idea, especially with type A aortic dissection, which we know has to be treated surgically. I'm sure as Dr. Palmer will talk to us about. So, for instance, this is important for a surgeon because it's a patient with DeBakey type 2 will have a less extensive surgery than a patient with a DeBakey type 1. Because the arch is involved in DeBakey type 1 versus in DeBakey type 2, the arch is not involved. So the surgery might not be as extensive. Recently, though, the Society for Vascular Surgery and the Society for Thoracic Surgery came up with a completely different classification. This is a crazy classification. It is based on where the dissection exactly starts. We still have type A aortic dissection and type B aortic dissection, but now we have something else called non-A and non-B aortic dissection. And we divide the aorta into 11 different zones, as it wasn't even complicated to start with. This is important because endovascular therapy has really changed the way we treat patients with aortic disease. Risk factors for aortic dissection are listed here. And I'm sure they're being drilled in your head over and over again. And by no means, this means that if you don't have these risk factors, you are immune from aortic dissection. Anybody can get an aortic dissection. But what we're trying to say here is that if you have high blood pressure, you have high cholesterol, you smoke, you have diabetes, you are pregnant, you are at higher risk of having an aortic dissection. People who use cocaine are higher risk because cocaine increases blood pressure of having aortic dissection. If you have something called penetrating aortic ulcer, you have a higher risk. If you have connective tissue disorder, it's so important that I gave it its own slide. The reason why I put this slide here as a patient with connective tissue disorder is because not only if you have connective tissue disorder, you are at high risk for aortic dissection, but you also present a different challenge from the management standpoint. So your surgeons are challenged just as much as it is hard for you. Because when you are suturing someone who has Marfan syndrome, or the tissue of someone who has Marfan syndrome, Loeys-Dietz, or Ehlers-Danlos syndrome, the tissue is so friable so that the stitch might not stay. So we are very, very challenged It's a big challenge to offer an operation in patients with connective tissue disorder. So we like to educate these patients not to ignore any signs of aortic dissections, which we'll talk about a little more. So if you look at all comers, patients with type B aortic dissection are usually 10 years younger than patients with type A aortic dissection. However, patients with aortic dissection, type A aortic dissection, is considered a lethal condition. About 20% of patients who get a type A aortic dissection don't make it to the hospital. If you do make it to the hospital, the chance of you dying is about 25% in the first 6 hours if you're not fixed surgically. If you go on for 24 hours, the chance of dying is about 50%. And at the end of the week, the chance that the patient with the type A aortic dissection will be alive is only about 40% without surgery. So that's why type A aortic dissection is considered a surgical emergency. Put otherwise, the chance of someone dying from aortic dissection is 1% for every hour for the first 24 hours. So very important not to ignore any sign. So in surgery, we offer a patient an operation when the risks of the disease outweighs the risk of surgery. So the benefit of the surgery has to be higher than the risk of the surgery that we're about to offer. So for patient with type A aortic dissection, if a patient with a type A aortic dissection were to come today, we treat them medically. How did they do? In about 30 days, if we look at the outcome based on the data from IRAD, about only 40% of them will still be alive at 1 month. But if we fix them with surgery, the chance of survival is about 75 to 80%, used to be. So follow me carefully. This is for patient type A aortic dissection. For patient type B aortic dissection, giving them surgery, the chance of death is actually higher than patients with type A aortic dissection, about 26% chance of death. But for medical management, so let's treat them just with blood pressure. Chance of death is about 10%. So that's why type B aortic dissection, we manage it medically. Type A aortic dissection, we give them medication. We manage it surgically. So this was true, however, up until the year 1990. In year 1990, something very important happened. What had happened is stent grafts became available. The stent graft became available. They weren't applied to treat patients with aortic dissection by patients with aortic aneurysms. It used to be if a patient has an aortic aneurysm, they come into the hospital, we make this big incision, we open them up, we clamp the aorta above and below, we cut it out, we repair them. They have a tube coming out of their nose, they have an ET tube, they go to the ICU. They in the ICU probably 3-4 days, they're not eating, and then they go home. I just fixed an aneurysm for someone today and this morning, and they're eating already. They're gonna go home tomorrow. And that was all because of this stent graft. The question then became, can we just apply the same principle that we use to fix aortic aneurysm to fix patients with these other entities, such as aortic dissection, penetrating aortic ulcer, intramural hematoma, or trauma? The answer is perhaps. Here's a paper, again, from IRADS. IRADS is a registry of aortic dissection patients. It's a worldwide registry of aortic dissection patients, and MHI, Minneapolis Heart Institute, with the leadership of Dr. Kevin Harris, we are part of it, and we've been part of it for the longest time. This paper looked at 30-day death of patients with aortic dissection, type B aortic dissection. If a patient has open surgery, about 32% of the patient were dead at 30 days after open surgery. Medical management, 10%. What about this new therapy, endovascular therapy? 7%. chance of death. So perhaps we can work on decreasing the chance of death after someone has a type B aortic dissection. So then who do we treat? And when do we exactly treat a patient with type B aortic dissection? There are 3 phases that I'd like for you to keep in mind for aortic dissection. The first phase is before 2 weeks, anywhere between day 1 to day 14. The second phase is 2 weeks to 90 days, and the third phase is 90 days on. This becomes important. Who do we treat and when do we treat them? Well, we've already discussed that if you have a type A aortic dissection, that's an emergency, right? Dr. Palmer would do either an ascending aortic replacement, or might do a hemi-arch, or might do a procedure called a Fosen alpha trunk. If you have a non-A, non-B dissection, meaning that your arch is dissected, or you have a type B aortic dissection, that depends. It really depends on what the pump is doing and what is the state of your gut and your lower extremity. Is your intestine getting blood flow? Are your kidneys getting blood flow? Is your liver getting blood flow? Are your legs getting blood flow? That's what we're asking. That's the question we're asking. Provided that all the other organs downstream are getting blood flow from the heart, you have, meaning that the flap is not collapsing, so depriving the other organs blood flow, we say, let's sit still. However, if the patient's not getting blood flow to the gut, they only have 6 hours and then they're gonna die. If you have no blood flow to your legs, after 6 hours, your muscles start breaking down into chemicals that circulate through your body, causes the entire system to fail, and the patient dies also. So we like to restore flow in those cases. But if a patient presents with no malperfusion, that's what we call it, meaning the gut's working fine, the legs are working fine, we hold still. We don't treat it. We wait. However, there are certain risk factors that will lead us now, because of endovascular therapy, to treat patients before who did not have any malperfusion. And the treatment is done in the subacute or chronic stage. And I'll explain the reason why we do treatment in the subacute phase. In the subacute phase, there are certain risk factors. Even though a patient can come in and they look really, really good, I have listed 11 risk factors here. They are all based on really, really good data in the literature. If a patient comes in, the first thing we do with a type B aortic dissection, we give them pain medication and we give them blood pressure medication. Once the blood pressure is lower, the pain goes away. If the pain is not going away, that tells the surgeon that you got to go ahead and fix this patient, because if you don't, the aorta is going to rip. They'll die. If we give you blood pressure medication and you're not responding, your blood pressure is still high. We like it 120 or below. If it's still too high, this is a marker to us as a surgeon that this patient will not do well long term. This should probably be fixed. If you have a total aortic diameter, I'll show you again later on, that is greater than 4 centimeters. This is a marker that the patient will not do well. We got to fix them. If the aorta already measures 5.5 centimeters, the patient already has an aneurysm. That means we need to fix it. If the false lumen is greater than 22 millimeters, we fix these. So I have listed, or the entry tear is greater than 10 millimeters, we fix these. So to emphasize all these elements I have listed here, I'm going over 4 cases of patients that I have personally treated. And at the end, I'll be asking you why did we fix the patient and what's the take-home message. Here's our first patient. He's 47 years old in the year 2012. Who presented with a history of hypertension, presented to 212 Medical Center with chest pain going to the back and fatigue. He was scanned. Can you play that? Is there a way I can play that? No, probably not. Can you play? There's a play on the CT scan. The other one on it, yes. Play that. Yep. No, push play again. I'm sorry. Push play. You can click on it anywhere, it'll play. Yes. Okay. So when you look at the CT scan of this patient, you can see that there's a tear, or a rip. You can see the line, right, that started just distal to the subclavian artery. The subclavian artery is the artery that supplies the left side of the arm and the back of the brain. You see that that tear starts at the left subclavian artery, comes all the way down to the left iliac artery, or the left side of the leg. The patient has no malperfusion, is doing completely well. So he was treated at Abbott Northwestern with antihypertensive medications, and he did quite well. He went away and came back and followed up for one visit at 1 month, and then was lost to follow-up. If you look at his CT scan, you can say, well, he's doing fine, he has no malperfusion, he's probably going to do well. However, a careful review of the CT scan, you see that this patient has an entry tear that's about 10 millimeter big. So the entry tear, the careful scrutiny to the CT scan will tell you that this is a patient that you have to follow very, very carefully. If you don't, they probably won't do well. Sure enough, this past year, Dr. Palmer and I were actually on call. He shows up. He woke up from sleep, now feeling his left leg completely paralyzed from the left side with severe chest pain radiating to the back. Now play the scan again, the CT scan. You can see that not only does he have an 8-centimeter aneurysm just distal to his subclavian artery, so his aorta is developing to an aneurysm, now he has a type A aortic dissection. So this is an emergency. So we took him to the operating room, and we did a procedure. Oh, I'm sorry, that's Dr. Palmer actually talking. You can kill that. We did a procedure called a frozen elephant trunk. So here I have gain access in the groin. I put a wire up, and I'm doing an ultrasound inside the blood vessel to see where the true and the false lumen is. Dr. Palmer opened the chest, that the chest opened, and she arrested the heart. She'll talk to you about this, I'm sure. And she can see my wire here. So she pulled the wire out. Now we have the wire from here. She replaces everything. Once she's done, I deliver a stent graft more distally. And you can see that what you see over there, that's a completion angiography on the lower side, on the left side. The patient has done well. Now, can you play the picture in the middle, the bottom middle one? This is a follow-up CT scan. I looked at him. I said, you know, you will need another operation. I guarantee it. But on follow-up CT scan, you can see that his aneurysm that was measuring 8 centimeter now is at 3.8 centimeter, even though not all his aorta is covered. So at this point, we hold tight. We keep monitoring him. He's very young. He's like 54. So chances are he'll probably he'll progress into an aneurysm, which will fix. This is what happened with him. Because the operation was done emergently, and because they had an aneurysm, the debris from the aneurysm washed out to the left leg during the surgery. And we had something called microembolization. So the distal vessel, his toes started dying. Even though on angiogram, you can see that the blood flow is really good. He ended up actually losing his leg below the knee. But he's a young man, is very strong. He has a prosthesis, is already walking on a prosthesis. You see him, if he were here, you would never know that he had an amputation. He's doing quite well, and he never misses an appointment now. So the take-home message is, this is a chronic disease. If you have a case like this, you have to come back and see us. Here is a case, a report that one of our cardiology fellow, Dr. Sharma, looked at. We look at 172 patients that we treated at MHI. We broke them down into two groups. those that followed up, that showed up to the first appointment, and those that did not show up to the first appointment. Fortunately, majority of patients show up to their first appointment. How did they do? Well, it so turned out, if a patient had shown up to the first appointment, they are 75% chance more likely to show up to their second and third appointment. But those that do not show up to their first appointment, the chance of dying is 40%. So 40% of them died, just they didn't show up to their first appointment. Of the patient who showed up to their first appointment, if they stay compliant, meaning they kept coming back and visiting with the doctors over and over again, the chance of dying is twice less than patients who do not follow up. Again, the take-home message, follow up with your physician is extremely, extremely important. Here's a second case. This is a 58-year-old gentleman. He's an elder in the biggest Jehovah's Witness church here in Minneapolis, who had an ascending aortic aneurysm and an aortic valve dysfunction. He went to the University of Minnesota and underwent an ascending aortic aneurysm repair and a procedure called a Bento procedure. The procedure seemed to have gone well. On the second day after his operation, he started complaining of severe chest pain radiating to the back. They scanned him. He has a huge dissection, as you see here, that starts just distal to the subclavian artery all the way down. He's only two weeks out. They fixed him with, they treated him with antihypertensive medications and then sent him home. He comes back 3 weeks later. If you can play the CT scan, please. Now what you see, he has a 6-centimeter aneurysm just distal to the subclavian artery. His true lumen is very, very compressed. His false lumen, you can see, is bigger. And he is now 4 weeks out, and he will not take blood product. The cardiac surgeon, who I know very well, a friend of mine, called me and said, "Jesse, is there a minimally invasive option you can offer this patient?" I said, "Well, transfer him over. Let's see what we can do for him." I looked at him very honestly, man. It told me, "Dr. Manunga, I know you're going to do your ultimate best. Don't give me any blood. If I die, let me go." So we took him to the operating room. And what you have here is I have done a procedure called a carotid subclavian bypass. Essentially, I made a small incision here. I unhooked this artery that goes to the arm. I hooked it up to the carotid artery, the artery that supplies the brain on the left side. Then I brought a stent, and I put a stent just past to the subclavian and all the way down to the celiac artery. Usually, I do not balloon. We don't balloon in an acute setting, but in this case, my goal was to fix his aneurysm. So you can see I am ballooning, stretching the aorta, and you can see the true and false lumen or the septum is ripping, which is a very unsettling feeling in the operating room because you think patient's going to bleed out. So that's completely ripped out. And now, if you can play the CT scan, the middle CT scan, this is about 6 weeks after that. You can see that his aneurysm is completely healed. Gone. No aneurysms. Just from the stent that I placed there. However, distal toward the stent is at the level of the celiac artery. That's the artery that supplies the liver and the spleen. He's starting to grow. He's at 38 millimeter. I'm going to wait until it's 35, is a 55 millimeter. I'll fix him. But I can always fix them through the groin. This is no big deal. This is actually easy now. I can fix them with a fenestrated or branch endograft. So the worst for him is really behind him, as long as he stays compliant. So here's a number of other studies that I put together. If you look at this, you look at people who have published constantly on aortic dissection. After your aorta is fixed, the chance that you will need another operation is about 20%. So it's very important to come back and visit with us. Here's your third case. Fixed it last year. Yes, last year. 73-year-old male from Plymouth was at the gym working out with his buddies and got queasy, passed out, lost consciousness. They took him to West Health and they did a CT scan. If you can play the CT on the left-hand side, please. On CT scan, you can see that he has an aneurysm, a dissection rather, that starts at the subclavian arteries coming all the way down. But the difference here is that you can see that the false lumen is thrombosed, meaning there's no blood flowing into the false lumen. This is a predictor that this patient's going to do well. In fact, I looked at him, I said, with blood pressure medications alone, you're going to do well. I won't operate on you. Play this other CT scan on the left side. 3 days later, he's not doing well. I scan him again. You see that he now has an aneurysm that measures 5 centimeters, and his true lumen is very collapsed. He's barely getting any blood flow to his gut. This goes to show you, just because I told you that you're going to do well, that doesn't mean that I'm God or you're going to do well. So most people don't, a lot of the people just won't read the textbook. So in this case, I took him to the operating room. So this is what I did. I used a device called a Gore left subclavian branch device. So I gained access from the left arm, and I fished a wire and pulled it out to the right groin. Now I have access and through access. And I used this device instead of doing a bypass on him because it was a little on the bigger side. So I put this new device and then expanded his aorta significantly. This is his follow-up CT scan. You can see that's where we started on the left side. This is immediately post-operatively that his true lumen is completely expanded. And this is when I saw him, I believe a month ago. You can see that his entire aorta above is healed. However, below the kidney arteries, his aneurysm, his aorta now is 5 centimeters in the greatest diameter. I have him on schedule next week for an endovascular repair of his aorta below the kidney arteries. My very last case is that of a chronic aortic dissection. What if you go on for a long time? What if the gentleman that Dr. Palmer and I had fixed came to us and did not have a type A aortic dissection? What do we do with this? You can play this. This is a 77-year-old male with a history chronic type B aortic dissection. He was treated with medication 10 years ago. Now he comes back, follow up with me, has a 7.2 centimeter, what we call Crawford extent 2 thoracoabdominal aortic aneurysm, meaning his entire aorta from the subclavian artery down to the iliac artery is expanded. So now we have to fix it. How do we do that? So for this gentleman, I designed a graft. This is a patient that I treated in my clinical trial. This is a graft, a stent graft that is not designed for him, but I'm going to custom made, essentially like custom making a suit to accommodate him. The device which I deploy here on the left side, you see that's deployed. Then I make holes to allow blood to flow into the celiac artery, the superior mesenteric artery, the right and the left renal artery. I collapse the device posteriorly so that once I introduce it through the femoral artery, I can rotate it so that holes will line up perfectly with the vessels. Then I put it back into the delivery system so that I can put it through the femoral arteries. We go to the operating room. This is a big deal. I have a neurologist with me all the time because I'm going to cover his aorta from here all the way down to here. His spinal cord is not getting any blood flow. And he's going to sleep. There is a chance that when he wakes up, he does not move, he can't feel his legs. But I want to be talking to him. I want him to be answering my questions while he's asleep. Move your legs, please. But he's going to be asleep, so he can't do it. So the neurologist hooks him up to this monitor called motor evoked potential and somatosensory evoked potentials. So essentially, at any given time, every second, the neurologist is telling me, Jesse, there's no good blood flow to the spine, or there's good blood flow to the spinal cord, or there's good blood flow to the spinal cord. Working together, this is a completion angiography here. A lot of the times when you guys go to the hospital and you see a patient after surgery, you see surgeons. However, in the background, this is what it looks like. There's a ton of people working behind to make any surgery successful. All these people, and this is not even all of them. Some of them came and went, but this is the whole team. This is what it takes to get you through this type of surgery. We follow these patients very closely. You can play that, the CT on the left. You can see that this guy has metal, literally a stent, from close to his heart all the way down to his legs. And his aneurysm is fixed. Even though it's fixed, we still follow him. Every single year, he sees us. Thank you so very much for indulging me and for the invitation again. If you have any questions, I'm happy to take them either now or later on. Thanks.